Since my children were young, I've taught them that many times people handle differences differently. That even though we may celebrate differences, some people get afraid of differences. And that fear, that discomfort can lead them to do things that might cause harm. And I explained that we all have differences. Some are more obvious than others. And that we all might feel discomfort sometimes for certain differences, while others we feel completely comfortable and celebrate. I bring this up because I've been reflecting on the US versus Skrmetti case, and I have read the decision. And as I've been reflecting on it, I think about the people that are celebrating the decision. And I need to believe that those that are celebrating the decision are celebrating it because they truly believe that they are protecting kids. And so, if that is you and you came here to take a listen because you believe you are protecting kids, then I want to offer you to take a listen today at my medical perspective on this decision because all it will do for you is either you'll believe what you believe stronger or you'll reconsider. And at the very end, so make sure to listen to the end. At the very end, I am going to give you a test to see if what you believe is truly about protecting kids or is it really coming from a discomfort of something different, whether you recognize it or not. So there will be a test at the end to help you distinguish, is this truly about protecting kids or is this really about a discomfort I have about transgender kids? So let me get started with my reflections. The first thing I want to say from a medical perspective was the idea that they made the comment that this is not sex discrimination because, and that was what they were to decide, because it was about diagnoses, different diagnoses. And so, for those that don't remember, and I encourage you to go back and listen to my episode from December where I had listened to the hearing and gave my reflections of the medical perspective of the arguments within that hearing. You can go back and listen to that. But a little summary of what was being argued was that the plaintiffs, the families that wanted to end the ban on gender affirming care, that wanted gender affirming care, not to be allowed to ban it, the argument was that this is sex discrimination because if a male patient desires puberty blockers to stop puberty, or if a male patient desires testosterone to start puberty, then they can have it. But a female patient can't have puberty blockers. A female patient can't have testosterone to initiate puberty. And so, because those two different sexes, they're being treated differently. And that was the argument. Now, the decision was that it wasn't sex discrimination because that's not what they were comparing. What they were saying is that no, it doesn't matter if you're male or female. If you have gender dysphoria, you're not being treated. So it's not sex discrimination because it has to do with the diagnosis of gender dysphoria. Now, I'm not a lawyer, so I can't speak to the legal language of all of this, but from a medical perspective, I get a little bit baffled on this decision because I could understand if it was Ozempic. Ozempic was created for diabetics. It helps with blood sugar control. That's what's created. And guess what? Once they started using it, they noticed that it did something else. They noticed that it affected the brain in a way that it decreased cravings, decreased appetite. And so then it became used for weight loss. So that to me saying, well, it's two different diagnoses because the medication is being used in two different ways, that the mechanism that you're asking of the medication are two different things. But in this case, In this case, when we think about puberty blockers, for example, puberty blockers are being used to stop puberty. They're being used to stop puberty out of the concern of the distress of going through puberty and the desire to buy more time. That's why puberty blockers are used for precocious puberty. Now, if you thought I was talking about gender dysphoria, you're not wrong that we use them for the same reasons, and you've just proved my point for me. My point is these medications are being used for the exact same purposes and the exact same mechanisms. Whether it is for precocious puberty or whether it's for dysphoria, they are being used to stop puberty out of concern of the distress of the puberty beginning, to buy more time. And I bring this up because a lot of times in the arguments, if you go back to that episode and listen, you'll hear me talk about this. But a lot of times in the arguments, they brought up the fact that gender dysphoria, that the medication is being used for psychological reasons, and that in precocious puberty and all the other diagnoses that might use some of these medications are being used for biological reasons. And I want to offer you that in both cases, they're being used for biological reasons. And in both cases, they're being used for psychological reasons. And that's true whether you're talking about puberty blockers or whether you're talking about hormones. We use hormones in delayed puberty to start puberty. That's the goal for both of them. And the age in which you start it is to help with the psychological distress. In delayed puberty, there is psychological distress not going through puberty with your peers. That is why the decision to treat delayed puberty has been pushed down younger because they recognize the distress was great. So one of the reasons that you use hormones in delayed puberty is because of the psychological distress. This is not unique in healthcare. The psychological component to treatment is considered as part of the decision making. It is not unique to gender affirming care, nor in these treatments that they're saying, but we're using it for two different diagnoses. But you're using these medicines for the same reason. They're acting the same way. The mechanism you're asking it to do is the same in each case. So I don't understand why the distinction of these two different diagnoses when it's basically the same treatment. Yes, for different diagnoses, but same treatment, asking the medicine to do the same thing in the same age group. If anything, puberty blockers are used younger. And so I don't understand the difference of concern of side effects when it's used for gender dysphoria than precocious puberty. The side effect panel is the same. The research is the same. For me, an analogy for this would be like cisplatin. If you don't know what cisplatin is, it's a chemotherapy, and it's a chemotherapy used in a lot of different cancers, including testicular cancer and ovarian cancer. And there's a list of side effects. And to me, it'd be like saying, you know what? I don't think we should use cisplatin anymore for ovarian cancer because I think those are bad side effects. There's nothing to do with sex. It has to do with diagnosis. The medicine is the same. Now, as far as how long and what the cycles are like and the dosing, yes, that might be different. But the mechanism in which you're asking, what you're asking the medicine to do, the way it is working is the same. Just like for precocious puberty and gender dysphoria for the same. Just like for delayed puberty and gender dysphoria, it's the same. And I think if anyone said, I don't think the side effect profile is okay on that medication, so we should stop using it, the side effect profile would be the same for both. My second concern in regards to the decision that I read was that they make the comment, it's not because these patients are transgender. No. It's because of their diagnosis. It's because they have gender dysphoria or gender incongruence or gender identity disorder. Any of those three names. But it's not because they're transgender. It's because of the diagnoses. Only a transgender person could have those diagnoses. So that doesn't make any sense to me. And why they chose these three terms, gender dysphoria, gender identity disorder and gender incongruence has to do with the ICD codes. If you don't know what ICD codes are, when you go to get treated and you get billed, there's an ICD code that goes with the diagnosis. You have to have that for billing purposes. There's no code for being transgender. There's only a code. And the ICD-10, it's gender identity, gender dysphoria. And the ICD-11 that's coming out, gender identity disorder is not there. Gender incongruence is there, and gender dysphoria. So those terms that they specifically say, it's that. But there's no ICD code for being transgender. And yet these things are like, well, it's not about being transgender, it's about the diagnosis, but only transgender people have that diagnosis. For me, it would be like if you were trying to argue the case. There's a statistic, something along the lines of for women presenting patients in the emergency room, they are 13 to 25% less likely to get opioids for abdominal pain. And so if you were going to look at this and say there's discrimination because those that identify as women are getting less opioids than those that identify as men. If you made that case and someone said, no, but that's not the diagnosis, so it's not sex discrimination because the diagnosis is abdominal pain. So it has nothing to do with sex. To me, that's the parallel. Of course, there is no ICD code for being a woman, a cisgender woman. There is no ICD code for being transgender. So to say, well, it's not discriminating against transgender people, it's about the diagnosis, is a little bit silly to me. It would be like saying, you know what, we're not going to treat diabetic retinopathy. It's nothing against diabetics. It's the diagnosis of diabetic retinopathy that we're not treating. We're not going to treat the diagnosis of diabetic retinopathy. Oh, wait, only diabetics get diabetic retinopathy? Yes, only diabetics get. But it has nothing to do with diabetics. Hey, if they get a different type of retinopathy, we'll take care of that, but not diabetic retinopathy. That to me is the parallel. To say, oh, it's about the diagnosis, but who gets that diagnosis? One group of people. With that in mind, in the writing of the decision, they talked about these treatments, recognizing that these treatments are used in similar fashions, in different diagnoses, that you can use it to treat, and this is their language, congenital defects, precocious puberty, disease, or physical injury. And then they go to define congenital defect. Now, this is not a term I would use, but this is the term that is used in the document. So I am using it here because it is used in the document. Congenital meaning born with. They use the term defect. I would use the term biological variation. That in the writing, it's defect. And the definition they give for it is something present in a minor that is inconsistent with the normal development of a human being of the minor's sex. This is their language. Inconsistent with the normal development of human being of the minor sex. I would offer that gender dysphoria fits this definition. And what I mean is the average baby born assigned male at birth is going to identify as a boy or a man. The majority. That's the norm. That's most likely to happen. So what's inconsistent with that, what's less likely to happen, is that somebody does not identify as what they were assigned at birth. That fits the definition. Yet they made the point to say everything except for gender dysphoria, even though it fits the definition. Everything except for that. Why? Why do they make an exception for it? I didn't see. I can guess, having listened to the arguments. The fact, as I mentioned before, that they kept referring to it as a psychological disorder, as if this isn't biological variation the way heterochromia is. What is that? People with two different color eyes. It's a biological variation. There's nothing wrong. People are just born that way. Or situs inversus. Rare, but I've seen it. Situs inversus is a biological variation. It's inconsistent with the normal development. Situs inversus is when all organs are flipped. So the heart for the majority of us are on the left side with situs inversus on the right side. Nothing wrong. It's a biological variation. Being transgender is a biological variation. It is part of the beauty of the diversity of nature. We see it in nature. But I believe the defendants did a very good job of drilling it into the heads that this is a psychological disorder, and so for some reason should be treated differently. Is there a psychological component? Yes, but most of that psychological component is because of the way the patients are treated, the way people are treated by society, by families, by the community. A lot of the kids that we see that transition young before any medical care, when they're in alignment, and patients of all ages, people of all ages who are living as a true self in alignment with themselves have minimal, little to no dysphoria. You can see it. In fact, they have times of gender euphoria, not dysphoria, when they are treated appropriately, consistent with their identity. The third and final piece that I want to talk about is that in the decision, they write about the concern to protect the kids. And I want you to listen because it's here if some of these are your concern too. A permanent change for life. Not mature enough to decide and understand the ramifications. Not enough long-term data. The numbers are increasing. There are other methods to treat. If you think for these reasons, a treatment should be banned, permanent changes for life, not mature enough to decide and understand ramifications, not enough long-term data, numbers are increasing, there are other methods to use. If you think that these are all valid reasons to ban a form of healthcare, then what you are telling me is that you think gastric bypass should be banned for minors, because that is what I just described to you. Those are the arguments against gastric bypass for youth, yet they are done. Same arguments. It's a permanent change for life. They are rerouting the GI system, and it is permanently done. Those kids will require vitamins and minerals for life. The argument they're not mature enough to understand that decision that they are making now and what that means and all the behavioral changes they are going to have for the rest of their life. There's not enough long-term data. In fact, there's less. This treatment, this protocol for the specific type of gastric bypass they're doing now is younger than gender-affirming care. They don't know what a kid who gets this done at 13, 14, 15 years old, what that's going to look like when they're 60, 70 years old. They don't have the data. And the numbers of kids requiring gastric bypass is increasing. The number of surgeries for gastric bypass in minors is increasing. An argument often used is that there are other methods that could be used. But we're not here discussing gastric bypass. Nobody is talking about banning gastric bypass surgery. People are against it, don't get me wrong. But why aren't they banning it? Well, from my understanding, the reason they're not banning it is because they think at the end of the day, the decision is between the patient, the parents, and the healthcare team. Yes, they also have a healthcare team. They also require psychological evaluation to deem if they're mature enough, to deem if they can follow through. And even though there's a protocol which varies place to place on how long of a therapy they get and they need, the team can override the protocol if they think the need of the patient is greater. If they think that the patient is mature enough and doesn't have to complete whatever that amount of time is, and that the risk of not having the surgery is greater than the benefit. I bring this up because these are all the things that are brought up with gender-affirming care about the nuance with patients and how some patients may have different levels and amounts of therapy, and evaluation is different patient to patient. Yes, it is, as it is with gastric bypass, because you take it patient to patient and evaluate them individually to determine what is the best treatment weighing out risks and benefits. So I present this to you to understand from a medical perspective. Reading through, I was confused. I understood, and granted, I'm not a legal person, but the justification that it's a different diagnosis when the goal of treatment, the way the treatment is all the same. The confusion I had that the statement that it's not because they're transgender, it's the diagnosis when the diagnosis only affects transgender individuals. And the argument that the concerns and the need to protect youth with limited data are some of the concerns. We have other areas of medicine like gastric bypass in youth, but we are not here banning other things. We're doing research, we're evaluating, we're reassessing, we're allowing the teams with the patients and their parents to decide. And I told you at the beginning, there's a test. If when you realized I was talking about gastric bypass, you said, whoa, I didn't mean that. I might not agree with that, but I wouldn't ban that. If you think there's a difference, then your concern is not the permanent change and the ability to make the decision and et cetera, et cetera. Your issue is that the people that we are talking about are transgender kids. And that left me with my final question for the Supreme Court as I read through everything. The 6 that made the decision, it made me want to ask them, and I wish they had asked them during arguments, but again, I'm not legal. I don't know if it's something you can or can't do, but I wanted to know, do they even believe transgender kids exist? That it's a real thing? It is. Transgender people, transgender kids have existed across the world since the beginning of time. They're in various communities, various faiths, and when supported and get the treatment that is appropriate for each individual, they can thrive. I've seen it. They exist.